Thank you very much for the invitation. Really nice to meet everyone today. So I'm going to talk through my top 10 tips for doing collaborative research. Obviously, collaborative research isn't a methodology as such, so I've gone for a bit of a broader take about how we can do impactful research. So that's going to cover how we plan, how we deliver, and how we disseminate our research. So my first tip is to make sure that you keep yourself up to date, by which I mean with the literature in your particular field of interest. That's really important because that's how you're going to know what research has been done, where are the gaps, what might be interesting to look at. Make sure you're having a look at what the new methodologies that are being developed are. What can you learn from that? What can you adopt? What can you adapt? So how would you do that? Well, I would suggest subscribing to journal contents of contents tables that get emailed out whenever a new issue comes out. So, subscribe to the BJS. You can set up alerts on Google Scholar or PubMed for particular keywords relevant to your field, or perhaps the names of particular researchers who are particularly influential in your area that you want to keep track of. And go on social media. I think social media is brilliant for following journals, following other researchers, just keeping up to date with what everyone's doing. This is really important because the more you understand about what's been done already, the easier you're going to find to develop your own research ideas. Secondly, plan what your intended impact is going to be. You need to define a very specific research question that addresses an important evidence gap that you can robustly address using the resources available to you. So can you deliver the best possible study to address that question using the right methodology? So if you don't have the resources to do a randomized trial, and the randomized trial is the best design, well, is there a different question you could do where you can do the right study design? Maybe it might be an observational study, but which isn't necessarily suitable for a randomized trial. And think about, well, what is going to be your route to either practice or policy change? When you have the results, what are you going to do with them? So again, I would have a look at what research recommendations have already been made. NICE guidelines, for example, always have a section on recommendations for research. So NICE will be very interested in any research that addresses those. There's lots of research prioritization Delphis that are being published. So if there's one in your area, or James Linderline's exercise, have a look at that and see what the priorities are. I think in research, sometimes people try to keep what they're doing a bit hidden. What I would suggest is talk to as many people as you can, whoever will listen, so you can evolve your research question based on people's feedback and people's thoughts. And I think really important is keep up to date with what's going on in the wider world. Read newspapers, listen to podcasts, follow social media to understand what are the policy drivers and priorities right now. I don't think it's controversial to say that there could be a change of government soon in the UK. Well, what would be the implications of that for surgery? What will be the surgical research priorities in 12 months' time if there is a change of government? We can anticipate that. You need to build a team. We've already heard this from other talks today. You're not going to be able to do this on your own. In collaborative research, you're definitely going to need to have what you could call an inner team, probably half a dozen to a dozen people who you're going to share the leadership burden with, because this isn't a journey you can go on your own. Make sure you bring in multidisciplinary experts. That could be statisticians, health economists, people from other specialties outside of surgery, to make sure that you get the best input to design the most robust study possible and cover off all those niggly problems that will come up later on if you don't design the right study now. And develop a really diverse network. What that means is surgeons, other specialists working in different hospitals in different parts of the country, different parts of the world, because the more different data you collect, the more generalizable your data is going to be, and the more impactful it's going to be. Collecting it from 2 hospitals in your region is going to be less impactful than from different hospitals, rural hospitals, urban hospitals, coastal towns. Make sure you try and get the best possible bite of the cherry by getting the most diverse data. How do you do that? Well, to motivate people to take part in your research, it's really important to have a shared ownership of that study, what you could call a disseminated leadership. Empower people within your network to lead that study and to take credit for that. An inclusive and equitable authorship structure. Find like-minded people, again, through social media. And we know BJS, for example, was one of the first journals to really embrace collaborative research. I think something that Professor Alderson and Professor Winton now can be very proud of is the impact they've had on fostering this sense of collaborative research, bringing together thousands of people to do research together. Work with patients. You need to do that because that's going to increase the quality and the relevancy of your research. It's going to build trust and transparency. So find patient focus groups that you can present to, involve patients on grant applications, involve them on your committees, and think about how you can get diverse groups of patients involved at all stages. Not just the same people who always get involved in these things. Try to reach out to broader patient groups, different socioeconomic groups, different ethnic groups, religious groups, so that we have a really strong community input into our studies. Focus on data quality. This is really important. You want to have the highest levels of data completeness and accuracy that you can achieve. Now, we've heard that 100% data completeness is unlikely, but we can definitely do things that will significantly increase our data quality. Having a clear, concise study protocol that everyone understands, so that everyone across your study network, maybe dozens, hundreds of hospitals, all doing the same thing. Having structured training for your collaborators, could be through webinars, YouTube videos, so that they really get what your protocol is and what they should be doing. Building in data validation rules into databases so that people can't put in illogical values. And having a really good pre-planned structured process for chasing up missing data at the end of your study is really valuable, because that final push makes a big difference to your data quality. And as you're doing all of this, make sure that you build capacity. Your team should have people at different stages of the career stages. People here today from medical students to senior academics. You want the same in your study team. You want people who can guide and have experience and expertise, but you also want to bring people on who are enthusiastic and who you can grow through this process so they can take on more senior roles in the future. So we come to the bit where you've done your study, you've got your results, you need to disseminate them. What I would encourage you to do is to develop a dissemination toolkit, which is a way of engaging your research collaborators to push out your research findings to their networks. Make it really easy for people to do that, and they're more likely to do it. So have template PowerPoint slides where they can present that at their departmental meetings, perhaps comparing their local data that they've collected versus the national or the international data. Produce multimedia materials like posters and videos. Think about how you're going to disseminate to patients. That could include patient information leaflets. Encourage your collaborators to share on social media. Encourage your collaborators to go to conferences. Share out those opportunities. Don't have the same person always being the same person who presents at every single conference, the same slides. Press releases are really important, because the reality is that if you publish in a major newspaper, it's likely that more surgeons will read your research in The Guardian or The Times than will actually read it in a scientific journal. Certainly, policymakers are more likely to read it in the mainstream media. So work with your press office to draft a press release. That's a skill in itself. You need to refine, complex research to find a few key messages that are going to really resonate with the general public. What do you want people to take away from it? And work with your collaborators, particularly if you've got international collaborators, to share this via their own channels, through their own press offices. Make sure you follow your press office's advice. That's a whole talk I could give on a separate day. But with COVID surge, so some of you will be aware of the work we did around COVID surge, we managed to have a really big impact, including on the papers we published in BJS globally, by translating press releases, empowering our collaborators to issue those press releases through their own networks, through their own universities. And that led to the kind of policy impact that we saw. So engage policymakers. They're not going to read your research realistically. So what you need to do is to prepare a 1 or maybe 2-page policy brief that summarizes your key findings and recommendations. Again, I think online you'll find lots of information about how to optimize your policy briefs. Identify who your key stakeholders are. That could be the colleges, associations, Ministry of Health, think tanks, and actively engage them. They are busy people. They're not going to find your research out there somewhere in the internet. You need to go to them and present your research actively. So, but always think about how can you create a narrative for why your research is important to them. How does your research align to their priorities? They're not going to change what their priorities are based on what you think they should be doing. You need to sell to them why implementing your research finding will help them to achieve what they already wanted to do. Think about different types of outputs. That could be health economic models or other types of models. So what's not so important, I think often people talk about engaging policymakers at an early stage in research. The reality is, like everyone, policymakers are busy people. You know, I can't have everyone coming to me about their tobacco research. There's not enough time in the day. So actually, often people will say, well, just come back to me when you've got your research results and we can have a look at those together. Don't worry too much about what journal you publish your research in. I know we all want to publish in the highest impact journals. It's very prestigious. It's maybe good for our careers. But the reality is you can publish in the New England Journal of Medicine and your research might not have very much impact. You could publish in the BJS and it could be the most impactful research that year. And that's because actually a lot of the impact is about what you do after the publication, what you do with that data. It's an active process. It's just because you publish in a particular journal is not going to make that much difference. So yeah, submit your best research to the BJS if that's the right home for it. And really what I really wouldn't worry about is the names on the papers. I hear so often, surgical colleagues worrying about, should they put Professor so-and-so on this paper or, a different professor. Honestly, if you're looking to change things in the real world and have an impact, nobody knows who these people are. Nobody really minds. They're not going to implement the results because, Professor Tompkins is on the paper or isn't. I'm afraid that's just the reality of the real world. So, in summary, plan your study carefully. I think that's a key theme from today, isn't it? Plan everything once really well so that you can get a really high quality study out. Think about your research question. I think people generally underestimate how much time you should spend planning your research question before you even get to thinking about your methodology. Think about important topics. I've sort of suggested some there that over the next couple of years, the elective recovery is still a big issue. Prevention is going to be a big priority for government. Antimicrobial resistance remains one of our biggest potential risks. And I think workforce increasingly recognized as a big issue for research. Follow best practice to deliver high quality research. So I think we've sort of heard a lot about that today. And plan really carefully how you're going to share your research findings to maximize their impact. And I think that I didn't put this on the slide, but Chris Whitty, who's the Chief Medical Officer in England, talks about riding the wave. What that means is, when opportunities come, make sure that you seize them, you're ready to seize them, and you're ready to go. So I would argue, some people would call it opportunist to go from topic to topic, depending on where the money is or where the policy interest is. But, generally there's a reason why the waves are there and why they're coming in that way. So I think, try to break out of the silos of, I just do research on this one topic, and look more widely and how you can impact surgical care more broadly, because I think there's lots of really important things we could be doing. Thank you.
Any questions from the floor at all? Yeah.
Thanks so much. I mean, I think I and many people have always admired how open and disseminated, you're talking about disseminated leadership, and how open many of these collaborative groups have been. What do you think about kind of going to the next step, and this also links to publishing, in terms of having even more open data, sharing data really widely, and either through visualizations that people can then play around with online, or actually making the data themselves open? Is that feasible in terms of, confidentiality and data protection? And is that something that you've thought about and looked into?
I mean, this is clearly a really hot topic. I think BMJ have recently said that they will only publish research going forwards where the raw data is made available, I think. There's obviously big challenges there, big opportunities there, which are that it will break open access to data. People can replicate your analyses and make sure whether or not you've done it properly. Because at the moment, we often go off, it looks, when you've read the manuscript, it looks like it makes sense. Actually, the reality of what's gone on, who can tell unless you've seen the raw data? The challenges are, firstly, in my experience, often where we have data sharing agreements with other institutions to collect data, many institutions around the world will put in clauses saying, you will not release the raw data even if it is anonymized. So that is challenging in that sense. I think there's also an element around equity, in the sense that it would become very easy for someone to just become a bit predatory. You've collected the data, well, give me the data, I'll write the paper. I think there is something about the people who've done the work, often years and years and years of work, complex work, collecting data, that they should have, the opportunity to publish their data first. And, that might be more than one publication, potentially. I think this thing about, you must share your data as soon as it's available, is just a little bit unrealistic. But that said, I would be the first to say that when we're doing an analyses and writing our papers, we should involve wide authorship groups. This model of 6 top-line authors who take all the credit, I think that, again, BJS takes a lot of credit for that. I think that model is slowly going away, that we could actually involve large numbers of people actively in that process. But I think the raw data thing is probably a little bit early for that, maybe something for the future.
Okay, I've got 2 questions. So you've just mentioned about trying to get away from the 6 sort of top-line authors. The problem is that funders, sort of almost exclusively, or maybe not exclusively, but to a significant extent, will base some of their decisions on your research track record. So is there not a conflict there that you need that publication to get the next grant to run the next study?
Yeah, interesting point. And of course, the same thing goes for university promotions and, I don't know, what they call them, merit points, exactly. So I think the reality is that it's more about telling the narrative of what your role was. I was the chief investigator of this trial. I was part of the trial management group. Because just the fact that you're 5th in a list of 10 on the top line doesn't really tell me what your role was. You might have been quite passive, you might have been quite central. And I think that collaborative authorship model, what it offers is that greater granularity over what individuals' contributions were. The fact that it's not on the top line, I don't think that really matters, because I think when you're writing your grant application, you can put that into words. It's not a problem I've experienced thus far.
In terms of big collaborative studies, when does heterogeneity of demographics, economic status of your countries, when does that actually start to become a problem? What's the tipping point? Because surely that sort of heterogeneity, that noise isn't always a good thing.
Yeah, I mean, I think it's the same challenge as with any multi-center research, in that there's always a trade-off between how generalizable something is versus how the external generalizability versus how well it reflects what would happen in your particular setting. And the best thing would be to run a randomized trial on every single possible topic within your own hospital to get the best data on what works in your setting. But that's not realistic. It's also not realistic to do every single trial or every single study in every country. And so I think, particularly when we think about low middle income countries, they've historically, going back more than 5-10 years ago, were routinely excluded from the opportunity to take part in research. And actually there was very limited evidence base on what would potentially work in those environments, which are very different to, a high income country environment. So I think there's a lot of benefits to having a broader base. We can say that our data is more generalizable, but we also need to think through how we do sensitivity and subgroup analyses so that we can explore, as you say, some of that heterogeneity. It's also a question of, I suppose, what your research question is. It's not always the right thing to do a global study to answer every research question. So I think it's sort of working out what the right fit there is. But I think we need to do more rather than less global research going forwards. One of the things you mentioned is about how we describe the heterogeneity, and I think going back to the earlier point that we need to be better at describing the characteristics of our participants in terms of their, not just their age and their sex, which we usually do, but also their socioeconomic status, their religion, their ethnicity. It has to be said that is more challenging on a global level, and I've not yet found a good solution. How do we describe ethnicity on a global level without resorting to having thousands of ethnic categories, which makes it really difficult to make any sense of that. That is a bit of a challenge. And similarly, socioeconomic status. How do you compare that between the UK and Ghana, for example? Completely different settings and contexts. So I think that those are the big methodological challenges, how we iron that out going forwards.
Excellent. Thanks very much, Dimitri. Right, so come to our last statistical wisdom section.
Okay, so collaborative group research. So broadening slightly beyond more traditional statistical thoughts about design and analysis. But briefly, the question that I always think about this is, what does the collaborative skill require, and how will it shape your study? We can think about that in terms of the surgery. How will the surgery and related care vary between the different groups that are involved, and the wider that range, whether that's within country, multi-country, multi-continent, that all has implications. It also has other implications about the way that a study is conducted, and because of that, everything becomes more difficult, I would say, at scale to get coherent, consistent things, unless you accept less is more. And I do think that is true, that you will get bigger numbers with collaborative research, which is good, but I think it needs you to be very selective about what you're going to collect to get good quality data. So you're going to need more people involved, and so you need more people who are more disparate and more set in different locations to do the same thing. And consistency of approach is clear if you're going to get something that's usable and understandable and credible to others. And then the last thing I would say is collaborative group research is a great foundation for research. It's not great research per se. It's not great just because you got lots of institutions or lots of countries involved or lots of people all over the place, but that gives you the potential to have a really great study and to give a really good answer and to look at things that you couldn't look at if you just stuck to you and your mate or friends, wherever they may be. Larger numbers usually lead to greater precision, so statistically it's generally an attractive thing and very beneficial thing to get those larger numbers. It helps you look at the rarer cases, the more unusual circumstances, and you pick up the events that are maybe going to be missed in your local study of 100 cases in the last 5 years. Similar findings amongst that variable practice is reassuring. It's a very positive thing to find. And the advantage of collaborative research is also it helps us map out variation in practice at a scale. So that's an inherently useful thing to be able to do.